Hello, listeners, and welcome back to our podcast. We're having our annual meeting in Las Vegas, September the 1st through the 5th, called Ortho on the Strip. We would love to see you there. Please sign up and register, as the spots are going quickly. Welcome to the orthoPAC podcast with your hosts, Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Today you have me, Sam Dyer, giving you a couple of case studies. So why don't we jump right in? The first case study, we have a 72-year-old female who presents with complaints of pain over the right groin and anterior thigh after she stumbled going up some steps yesterday. She has had no prior injury to the hip or pelvis that she can recall, but states that this pain has been quite debilitating. She can barely transfer from a seated to a standing position and can only ambulate with an assisted device or if she's holding on to her son's shoulder. She says it's quite painful. She has not seen any bruising or swelling, but she's not sure what's going on as she's never had anything like that. Otherwise healthy individual. She has no significant medical issues other than hypertension and high cholesterol. She has tried a couple of ibuprofen alternating with Tylenol, and those haven't really helped much with her pain. She is well-developed, well-nourished, and no apparent distress, but she does appear somewhat thin in appearance. She struggles with transfers, and she cannot climb onto the footstool to sit on the exam table for an exam. There is no ecchymosis or edema noted about her hip or pelvis. Any motion of the hip causes her to wince and pull away. Her pedal pulses are 2+ and symmetric, and her distal vascular function is intact. She has full range of motion of the right knee and ankle with no obvious discrepancy there, but very limited motion of the right hip. So we got some x-rays, and we see some mild degenerative joint disease or osteoarthritis in the right hip, but there is no obvious fracture or bony abnormality other than the osteoarthritis. One note, her bones do appear to be somewhat osteopenic. So with all of this information, what would you suspect is the most correct diagnosis? And I'm going to give you a few options to consider. FAI, femoral acetabular impingement, osteoarthritis flare-up, sarcopenia related to hip sprain and pain, or an occult insufficiency fracture of the femoral neck. I'll give you a couple of seconds to think about that. What do you think? So FAI is a possibility, although at 72 and the acuteness of the pain, I think it's unlikely. And I could say the same thing about osteoarthritis. It typically presents as an insidious onset that gradually worsens, and it's associated with startup stiffness. I think it's unlikely that that's the primary problem. It just seems like there's more acute symptoms and limitations than I would expect from an osteoarthritis flare. Plus, ibuprofen didn't really help. Now, there was no fall or impact to the hip, and there is no known remote history of trauma. But that being said, a patient with osteopenia on films that has sudden acute groin pain and hip pain from stumbling and is unable to bear weight, I think we need to consider a fracture until we prove otherwise. And I believe this is the most likely diagnosis, and it turns out that was correct. Now, sarcopenia, for those that don't know, is a generalized loss of musculoskeletal integrity, strength, support, and function. It can lead to multiple issues such as fragility fractures, but in itself is unlikely to explain the acuteness of this patient's symptoms. A hip sprain is also possible, but given this patient's history and exam, further imaging is indicated. So, all that being said, what do you think are the next steps for this patient? So, what are the next steps for this patient? Should we rely on tincture of time and send her home with a PT order? Say, maybe give her a more routine dosing of the Tylenol and ibuprofen and follow up with a doc in a week? Does she need more diagnostic workup? How do you manage this person who comes to your urgent care at night at 6 o'clock with this condition? What do you do? How do you manage it? That's kind of what I'm trying to get at here. The correct answer should be that you protect her weight bearing. First and foremost, take care of the person. Wheelchair is probably going to be her best option, as with the sarcopenia, I doubt she's going to have the strength to use crutches. Pain meds are helpful, but we've got to be careful when we add something to the mix that might increase her instability and risk of falling, especially at night when she's getting up to go to the bathroom. As far as further diagnostic studies, MRI is the correct choice. So the rule of thumb for MRI versus CT when it comes to fractures is that MRI is best if the fracture is clinically suspected, but it's not obvious on the plain films. CT if there's a fracture on films, but we need more investigation of the extent of the fracture or if we're planning a treatment. And sometimes you need both, but in this case, MRI is the correct choice. So we get the MRI and it shows a non-displaced insufficiency fracture of the femoral neck of the right hip. So we were correct by treating her aggressively, by protecting her weight bearing, and by getting the study done. But what's the management of this problem? The management of this initially as a PA in urgent care is to protect the hip and get an MRI done and get her back as soon as possible to see a doc. As far as the treatment decisions beyond that, it really depends on your practice and your surgeon's preference. Given her age and osteopenia and few surgical comorbidities, I think most surgeons in my practice would proceed with a surgical procedure, either a cannulated screw or arthroplasty, which is a somewhat controversial option for hip fractures, but it is an option. Given that she does have a sarcopenia and osteopenia, an arthroplasty may not be a bad option. Cannulated screw fixation, like I said, is also an alternative. Other considerations with this patient, in particular, her social status: does she live alone? Does she need a post-op short-term SNF or skilled nursing facility placement? Much that you have to consider given her situation. So it's not always let's make the x-ray or the MRI look better. Let's figure out how we can best manage this patient given her situation. So my question is, what would your practice do in this situation? It's kind of good to know from start to finish, even if you can't really initiate that treatment at 6 o'clock at night in urgent care. What's your practice pattern going to be, or what's your doc's pattern going to be? And if you know that kind of information, then you can kind of get her going down the right path more quickly. Okay, if you have any questions about that, please send us a message or comments or whatever. Let us know what you think. Please don't forget about the Ortho on the Strip conference we have coming up. Registration spots are going quickly. We're also giving away some Amazon gift cards for early registration, so check out details on paos.org under CME.